Welcome, everyone. My name is Raj Gandhi. I'm one of the course directors, and I'm going to be speaking over the next 30 minutes on COVID-19 treatment and vaccines, along with my colleague, Dr. Arthur Kim. And I'm going to be focusing really on recent advances in treatment and vaccines, since I think we've all become aware of some of the older data. Now we're going to talk about some recent advances, as well as a nod to where we might be going with COVID-19. Before we get started, I just want to acknowledge the number of people listed here. Dr. Shrip Gulick, Arthur Kim, Jodian Pinckney, as well as Kate Devine. So the topics I'm going to be covering in the next 30 minutes are listed here, and these are really focused on what's new in COVID-19 treatment and vaccines. So first, we'll talk about new data on nirmatrelvir/ritonavir, also known as Paxlovid. We'll talk about new data on its efficacy in vaccinated people. We'll talk about some data which is pointing towards the future, not yet settled, in terms of extending the duration of nirmatrelvir/ritonavir in immunocompromised individuals, a particularly important group of individuals. Third, we'll summarize the latest on rebound. Fourth, we'll talk about a couple of new anti-SARS-CoV drugs that are on the horizon and the need for new drugs as we move forward in the COVID pandemic. Third, we'll talk about a very recently authorized anti-SARS-CoV-2 monoclonal antibody called pemivibart, and this has just been authorized in the last month or two for pre-exposure prophylaxis in immunocompromised people, and we'll talk about that authorization. And last, we'll just reflect briefly on COVID-19 vaccination, where we are now. So let's talk about these new advances in the context of a case. This is a person I saw recently, a 68-year-old man who presented with 2 days of fever, cough, and myalgias. His SARS-CoV-2 rapid antigen test was positive. His oxygen saturation was preserved. It was greater than 95%. He has a history of HIV. His CD4 count recently was 300. His HIV RNA is undetectable. He also, importantly, has a history of pulmonary hypertension. His medications include bictegravir, FTC-TAF, and he's also on tadalafil, which is being used in this case as treatment for his pulmonary hypertension, and he's on a dose of 40 milligrams a day. He has received 2 doses of an mRNA COVID vaccine in 2021, but he has not received any booster doses since that time. And so the question I was considering is, what should I treat, and if so, with what? So this is a kind of a schematic of how we think about treatment across the COVID-19 spectrum. And really, as we know, COVID-19 starts out as asymptomatic and pre-symptomatic. That's when you have a positive test but no symptoms. It then often progresses to mild illness. And mild illness here is considered fever, cough, sometimes taste smell changes, but no shortness of breath. From there, it can progress to moderate illness. That's when you have evidence of lower respiratory tract disease, but the oxygen saturation is preserved. It's over 94%. And then finally, when people are hospitalized, that's usually for severe disease. That's with hypoxemia, tachypnea, lung infiltrates that are extensive, and of course, critical illness is multi-organ failure. Now, the reason why this is important for treatment is because viral replication is most active, at least in the upper respiratory tract, during mild illness and moderate illness. And then it tends to wane off as people get further on in their illness, whereas inflammation comes to the fore as people develop severe or critical illness. And that's why antivirals are really focused on mild or moderate illness, like my patient, and anti-inflammatories are the cornerstone of therapy once you get to severe and critical illness. So throughout the pandemic, I've been involved with 2 different treatment guidelines, the Infectious Disease Society of America guidelines for treatment, as well as the NIH COVID-19 guidelines. The NIH guidelines in particular has been used very, very extensively, over 50 million views, but just this year has decided to sunset, and so there will not be new guidelines coming out from NIH. The IDSA, though, will continue to monitor this field and issue new guidelines as new drugs become available and new evidence comes in. So here are our current anti-SARS-CoV-2 antivirals. They start with anti-spike monoclonal antibodies. Many of the previously used antibodies are no longer effective against the current variants, but we will, when we get to prevention, talk about a new antibody. And these prevent attachment and entry. Once the virus enters, there's a protease inhibitor in the virus that nirmatrelvir/ritonavir or Paxlovid inhibit, and so that blocks viral replication through a protease inhibition. There are 2 drugs that are either under clinical trial or being evaluated, authorized outside of the United States. That's Insetravir, which we'll come back to, as well as simnoctravir, ritonavir. These are also protease inhibitors. And then once the virus goes through proteolysis, there's an RNA replication phase, and that's where molnupiravir works. That's where remdesivir works. And then two drugs, one under study, one authorized in China, remdesivir and obeldesivir, tongue twisters, are in that category. So here are the data that led to the current guidelines for the use of nirmatrelvir, ritonavir, remdesivir, and molnupiravir, and you can see them in order of preference. Nirmatrelvir, ritonavir was studied in the EPIC-HR study. This was in high-risk individuals, 88% reduction in hospitalization and death. Its pros are it's highly efficacious, it's oral, and there's reason to think that it's safe in pregnancy, but there are drug interactions that we'll talk about. Second on the list is remdesivir, 87% reduction in hospitalization and death in the Pine Tree study. Pros, advantages, highly efficacious, appears to be safe in pregnancy, few to no drug interactions, but its big con, disadvantages, it requires IV infusion. And then finally, molnupiravir, reduced hospitalization and death by 30%. It's oral, it's not anticipated to have drug interactions, but it has a number of cons. It's of lower efficacy, there's concerns around mutagenicity, and it's not recommended in pregnancy in children. Now, for all of these three drugs, all of these three trials were done in unvaccinated, high-risk individuals. And that's led many to wonder, will the same efficacy be seen in lower-risk individuals? So before we get to that, let me just say a word about drug interactions. Ritonavir inhibits CYP3A during the course of treatment with nirmatrelvir, ritonavir, and for an additional 2 to 3 days after treatment's been completed. And for that reason, some medicines cannot be co-administered, so such as rivaroxaban, amiodarone, rifampin, and the drug that my patient was on, tadalafil, for pulmonary hypertension when used at that dose. Other drugs may need to be held or markedly dose reduced, things like calcineurin inhibitors, and then other drugs may be safely stopped, things like statins. Three really useful resources. One is the NIH COVID-19 treatment guidelines has a nice list of which drugs can and can't be used. The IDSA also has a resource for clinicians. And then the University of Liverpool maintains an up-to-date COVID-19 drug interaction checker. So I'm going to now get into a couple of controversies in treatment of non-hospitalized people with COVID-19, and I'll reflect on some new data, the new data that represent new advances in COVID treatment. So we'll start off with, should vaccinated people be treated? And here I want to highlight a study that was just published in April of 2024. These are new data on nirmatrelvir, ritonavir in low-risk and vaccinated high-risk individuals. It's the so-called EPIC-SR study. Here's the citation, and a colleague of mine, Dr. Hirsch, wrote the editorial on this particular study. So what did we learn from this particular study? So EPIC-SR looked at nirmatrelvir, ritonavir in lower risk individuals. So what do they mean by that? To qualify this study, for the study, you had to either be vaccinated with a risk factor for severe COVID or unvaccinated with no risk factor. So that's why they call them a lower risk population, that they've been vaccinated and had a risk factor, or they were unvaccinated with no risk factors. Individuals were randomized to nirmatrelvir, ritonavir, or placebo for 5 days. There were about 1,300 participants, and here's some important information. 57% were vaccinated. About half had a risk factor for severe disease, things like obesity, smoking, and hypertension. Now, importantly, and this is when I get to the interpretation, I want to stress that only 5% of the study population were 65 years of age or older, and less than 2% had heart or lung disease, really serious comorbidities that place people at risk for severe COVID. This is time to sustained alleviation of symptoms did not differ between the two groups, the drug group and the placebo group, in terms of not statistically significantly different, and that was their primary endpoint. And when they looked at hospitalization and death, the rate of hospitalization and death was 0.8% in the drug group and 1.6% in the placebo group, but this difference was not statistically significant. Now, remember, in EPIC-HR, the high-risk population, unvaccinated, the risk in the placebo group was a little over 6%, so you can see that this was a much lower risk group of individuals. So as I think about the totality of the evidence, this is my perspective on who should be treated with nirmatrelvir, ritonavir. I think it should be reserved for high-risk patients, people who have a comorbidity or an age or other condition that places them at risk for severe COVID-19. The data that we just reviewed did not show a benefit of nirmatrelvir, ritonavir in vaccinated people, but as I stressed, they only enrolled a small proportion of patients who are at the highest risk for progression. over the age of 65, immunocompromised, substantial comorbidities. There are a number of observational studies that suggest treating vaccinated people is beneficial. And I think there's a likely gradient of benefit. Higher risk patients are more likely to derive more benefit. And that stands to reason given what we know about the number needed to treat for a variety of medical interventions. So my own perspective, and I think largely the perspective of the guidelines, is to recommend treatment for older individuals, particularly those over the age of 65 or older, people who are immunocompromised, or people who have serious comorbidities such as heart and lung disease, regardless of their previous vaccine or infection status. So advance number 2, and this is more, I would say, forward-thinking because these are data that have not yet been published. So these are the results of the EPIC-IC study, where IC stands for immunocompromised. And so this is looking at nirmatrelvir ritonavir in immunocompromised people with COVID-19. And what it's sought to do is to compare 5 versus 10 versus 15 days of nirmatrelvir ritonavir in immunocompromised people with COVID. Now, who was immunocompromised in this particular study? People who were on immunosuppressive treatment, for example, solid organ transplant recipients, people who were getting chemotherapy, immune cell depletion, such as CAR T-cell therapy, primary immunodeficiency, HIV with a CD4 count of less than 200, and recent and current corticosteroids. Now, severely immunocompromised, and it was a subset of individuals. There was 57 people out of the 150 who were in the study were severely immunocompromised, and these were people who had CAR T-cell therapy, B-cell depleting therapy such as rituximab, hematopoietic stem cell transplantation, or a heme malignancy. So these results were presented at a recent meeting at the Conference on Retroviruses and Opportunistic Infection, but have not yet been published, and so I'll caution us there that there may be some information yet to come. But in the overall population of immunocompromised people, they could not show an effect of prolonging therapy out to 15 days in terms of clearance of SARS-CoV-2. So in the overall population, no substantial impact on 15 days versus 10 days versus 5 days. Intriguingly, though, and this is more intriguing than it is definitive, in the severely immunocompromised subset, those 57 people, the median time to sustained clearance of the virus was numerically shorter with longer therapy, with 10 days and 15 days of treatment as compared to 5 days. Rebound and rapid antigen positivity were numerically lower with the 10 or 15 days of treatment as compared to 5 days, and there were no deaths. 2 severely immunocompromised participants were hospitalized in the 5-day group, but that's a small number. So where do I think we are with treating immunocompromised patients with COVID-19? I think clearly we need more data on optimal treatment, including more data of the sort that we'll hopefully get on duration of treatment and the role, if any, for combination therapy. Some people have tried combination therapy, but we don't have definitive evidence that it's beneficial. We also need new anti-SARS-CoV-2 drugs that don't interact with transplant immunosuppressive medications such as tacrolimus and sirolimus. And how best to treat immunocompromised people with persistent SARS-CoV-2 infection is still not known. There are individuals who will continue to have SARS-CoV-2 persistence, and we don't know if we should repeat a course of antivirals, extend the course of antivirals, or combine antivirals, and we certainly need to know that answer. So the next controversy is really more of a summary of where we are with rebound, because this has, of course, been a topic of a lot of discussion. And I'm going to summarize a lot of information in just a couple of bullet points. So what do we know about rebound after nirmatrelvir ritonavir? So we know that symptom and viral rebound for SARS-CoV-2 may occur even in those who are not treated. And that's an important point to counsel our patients. Even if they don't get treated, they might have symptom and viral rebound. The randomized trials have not found a link between nirmatrelvir ritonavir and rebound, but observational studies, including studies that define rebound differently and include more frequent sampling, suggest that rebound is actually more frequent after nirmatrelvir ritonavir than after no treatment. Now, some patients who have rebound do have high SARS-CoV-2 levels, and in some research studies, they can be culture positive, and that suggests that they might be infectious. But here is the bottom line. In my mind, most of these cases of rebound are mild and resolve quickly, usually within a couple of days. So my own perspective, and I think the perspective of a lot of us, is that it's important to counsel patients that rebound may occur, but would likely be mild. I do not suggest avoiding therapy because of potential rebound. And someone who is of advanced age, is immunosuppressed, or is at substantial risk of severe COVID, I don't think they should avoid therapy. If a person does have symptomatic rebound and whose antigen turns positive again, I do reset the isolation clock. And I generally do not retreat with imaturavir ritonavir, although this is being studied and there is an ongoing trial cited here to look at whether a repeat course of therapy would confer any benefit. So back to my particular patient, the man in his 60s with 2 days of fever, cough, and myalgias, who's got SARS-CoV-2, has got a preserved oxygen saturation. He is on an important medicine for his pulmonary hypertension, tadalafil at a high dose. He's been vaccinated, but not for several years. I did recommend treatment, but because the imaturavir ritonavir cannot be given safely with the high dose of tadalafil, we were able to arrange for him to get IV remdesivir, our second choice, and he had rapid clinical improvement. So now let's go on to advance number 4, and here we're going to be saying a little bit about new anti-SARS-CoV-2 drugs that are on the horizon. Where might we be in the future? And I'm going to summarize data on some of the more advanced drugs, the ones that are furthest along on this single table. The first drug is an oral polymerase inhibitor. It's an oral remdesivir analog, remdesivir. It's been authorized in China, and it's based on a phase 3 randomized trial that showed decreased viral load, time to sustain clinical recovery were more favorable in the people who got this oral remdesivir analog. It is not, as far as I know, being considered by the US FDA. Obeldesivir, though, which is a drug that's being studied in the United States and elsewhere, also is an oral prodrug of remdesivir. It's in phase 3 trials. My understanding is that some preliminary word is that it's not going to show up an impact, but more data is yet to come. We don't have really a formal presentation on obeldesivir in terms of its effect. 2 protease inhibitors we've already talked about, imaturavir ritonavir, which is FDA approved, but there's a newer protease inhibitor called simnatravir, which is authorized in China, also on the basis of reducing viral load and reducing time to symptom alleviation. Again, I'm not aware of it being considered in the United States, but ezetravir is one to keep your eye on. This is a protease inhibitor. It's authorized in Japan based on data I'm going to show you about decreased viral load and symptoms, and there is a large phase 3 trial that may report out soon that may be considered by the FDA. So this is the study that led to the authorization in Japan. It's called the Scorpio SR study of ezetravir. Again, it's a protease inhibitor. It does importantly have substantial drug interaction, so it's not going to solve that problem for us, and it has an extended half-life. This particular study that was published earlier this year looked at 2 different doses of the protease inhibitor versus placebo. About 1,800 participants, of whom about 1,000 started the drug within 3 days of symptom onset. What you can see is in terms of time to resolution of 5 cardinal COVID symptoms, it was slightly shorter, 7 versus 8 days. That was statistically significant in the protease inhibitor arm versus placebo, and that led to its approval in Japan. But the large phase 3 Scorpio HR study, which I think will inform the FDA, is fully enrolled, and again, keep your eye out for results. One topic that engenders a lot of conversation is, will treating acute COVID reduce the likelihood of long COVID? Dr. Kim already talked about some research into treatment for long COVID, but can we prevent long COVID? In one VA cohort study of about 36,000 individuals who got imaturavir ritonavir, over 200,000 people who did not, there appeared to be an effect in terms of reducing the likelihood of post-COVID conditions. You can see that in the graphic on your right, and that benefit was seen in a variety of populations. But, and this is a really important caveat, it's difficult to exclude unmeasured confounding. They tried to adjust for confounding, but sometimes it's just not possible to do that adequately. So really assessing the impact of treating acute COVID on the likelihood of long COVID is a critically important area for future research. So now we're just going to spend a moment on treatment of severe disease. This has changed less than, and there have been fewer recent advances in terms of treating severe and critical disease. So now we're in the part of COVID where inflammation has come to the fore. And I'll just show you a single slide that summarizes the NIH, the IDSA, and the WHO guidelines for treating hospitalized patients, and they largely converge. And I won't go through each and every detail, but just to say, hospitalized patients who are not on supplemental oxygen, all of the guidelines recommend remdesivir, and all of the guidelines recommend steering clear of dexamethasone if they're not on oxygen. And people on conventional oxygen, not high flow, not intubated, remdesivir is endorsed by the 3 guidelines. And it's always combined, I would say, with dexamethasone, and often combined with either a JAK inhibitor, baricitinib, or an IL-6 inhibitor, tocilizumab, depending on the particulars of the patient. And then finally, someone on high-flow oxygen, intubated, ECMO, dexamethasone really is the mainstay of therapy, and often we'll be adding a JAK inhibitor, baricitinib, or an IL-6 inhibitor, tocilizumab. And again, more details on this and other are in the NIH and the IDSA guidelines. So what do we still need for COVID treatment? And I think there are a number of desiderata in terms of what we need for the future. We need medications with fewer or no drug interactions. For our patients who are on calcineurin inhibitors, tacrolimus, sirolimus, we need drugs that we can use that don't interact with their essential medications. We need additional data on optimal treatment of immunocompromised people. We don't have the definitive treatment for immunocompromised people, and in particular, whether there's a role for combination therapy. We also need to know, how do we treat immunocompromised people who have persistent SARS-CoV-2 infection? This is perhaps the most challenging group of individuals that we're trying to treat today. And then finally, and I'll underline this, we need a better understanding of which patients are most likely to benefit from our oral therapies. We need a tiered or targeted approach rather than a one-size-fits-all. Right now, we have broad strokes, but we don't have that kind of personalized medicine or customized medicine that I think we need. Now let's switch from treatment over to prevention, and we're going to start with an advance in terms of this newly authorized antibody, pemivibart, and this is an anti-SARS-CoV-2 monoclonal antibody for pre-exposure prophylaxis. So just as a reminder, we probably all remember that in the past there was an authorization for tixagevimab, silgavimab, also known as Evusheld, and that authorization was withdrawn a little over a year ago in January 2023 because the Omicron subvariants were no longer susceptible. In March of 2024, however, the FDA authorized pemivibart for pre-exposure prophylaxis for adults and adolescents who have moderate to severe immune compromise and are unlikely to mount an adequate immune response after a vaccine. It's not authorized for treatment. It's not authorized for post-exposure prophylaxis and should be given at least 2 weeks after COVID vaccination. Here are some of the data that the FDA shared when they authorized this drug. First, before we get to the data, the way it's given is 4,500 milligrams IV every 3 months, but it has to be given in a setting where a hypersensitivity reaction can be treated, and that's because the rate of anaphylaxis was 0.6%, which is higher than after some other comparable antibodies. So it has to be given in a place where you can treat anaphylaxis, and there has to be a 2-hour observation period. It's rare, but it's an appreciable consideration. How did they come to this? It was based really on extrapolation and based on something called immunobridging. So there is a study called the Canopy study where pemivibart titers, which are defined as the concentration of the antibody divided by the effective concentration 50 to inhibit JN1, which is the current circulating Omicron variant. That particular titer was similar to titers of other monoclonal antibodies that were shown to be effective in terms of preventing disease. And this includes an antibody here called adintrevimab. This is the parent antibody of pemivibart. And this particular study, this particular parent antibody was studied in the EVADE trial, where it conferred 71% reduction in symptomatic COVID when given as pre-exposure prophylaxis. So what the FDA did is they did this immunobridging approach to bring this to authorization. And here are the groups that are examples of immunocompromised conditions. It's a list of immunocompromised conditions that I think many of us are familiar with at this point. It's very similar to prior authorizations. The ones I want to highlight perhaps as highest priority are people with hematological malignancies, people with CAR T-cell or stem cell transplants, and people who have had B-cell depleting agents where we know that there continues to be an important risk. And so in the last few minutes, I just want to reflect on where we are with COVID-19 vaccination. I'll call this advance number 6. And really, I'm just going to summarize the latest CDC guidance on how we should be vaccinating our patients. So for immunocompetent adults who have received 1 or more doses of a COVID-19 vaccine, the CDC recommends that they get an additional dose, either 1 dose of the Moderna vaccine, 1 dose of the Novavax vaccine, or 1 dose of the Pfizer vaccine. So this is for immunocompetent adults who've had at least 1 dose of a vaccine in the past. For people who are immunocompromised, and this is an important group, of course, these are the people we fear may not develop an adequate immune response. So if they've gotten 3 or more doses of any mRNA vaccine, underline 3 or more doses of an mRNA vaccine, then the CDC recommends that they get 1 dose of the Moderna vaccine, 1 dose of the Novavax vaccine, or 1 dose of the Pfizer vaccine. And then finally, in March 2024, so quite recently, the CDC endorsed that all people over the age of 65 should receive an additional dose of the what's called the 2023-2024 formula COVID vaccine. That's our current COVID vaccine. Just as a reminder, our 2023-2024 formula vaccine, our current COVID vaccine is a monovalent SARS-CoV-2 vaccine that's based on the XBB variant, and that's the one that we were giving in the fall, and that's the one that we're giving currently. And the CDC is recommending that people over the age of 65 should get an additional dose of that monovalent vaccine that's directed against recently circulating Omicron variants. And just as a reminder, since so many people have gotten COVID recently, if someone who's recently had SARS-CoV-2 infection, it's reasonable to consider giving their vaccine dose about 3 months later. So rather than give it too soon after an episode of COVID, it's reasonable and safe, I think, to wait for about 3 months. A couple of points about how can we build vaccine confidence in our patients and our colleagues. I just want to highlight the really, really low rate of adverse events and put this in some context. So billions of vaccine doses have been given for COVID. Serious adverse events remain very, very rare. The most common are ones that we probably some of have experienced, which is pain at an injection site, fatigue, and myalgia, but usually for a day or 2 at most. Myocarditis, pericarditis is very, very uncommon, about 5 to 10 per 100,000, mostly in males, mostly mild, and most recovered fully. Actually, in the last week or so, Dr. Kim pointed out a report debunking the idea that there's an association with sudden cardiac death in young people. Guillain-Barré, just as a reminder, is rare, and it's was seen only with the Janssen vaccine, which has now been withdrawn, not with the COVID mRNA vaccine. So just to put our patients at ease. And then anaphylaxis is very rare, about 1 in 200,000. And remember, the odds of being struck by lightning in a year are about 1 in 500,000. So many of these risks are just about there with being struck by lightning. My colleague, Dr. Jodian Pinkney, has done a really tremendous job in terms of advising and studying how we can pursue strategies to improve vaccine confidence and to lower mistrust. And here are some of her insights. And I would start with really trusted voices for our patients, their healthcare providers, their primary care physicians. In the case of people who are pregnant, their obstetrician. Having those trusted voices endorsing a vaccine is critical. And really even having some dedicated trust-building appointments. I know our times are often short. It's often hard to spend the time needed to build that trust. So have a dedicated trust-building appointment. She's also pointed out that there are some very useful collaborative patient and provider-led educational videos that are easily accessible and shareable with some positive framing. I want to highlight, and she highlights, the importance of long-term community engagement and then authentic community investment where there's where social determinants of health are authentically addressed. So I'm going to conclude with the last slide, and this is a slide I've often shown at the end of my talks, but I want to show it again because I really think that there are some important lessons that we can draw from our experience with HIV in the 1990s and COVID-19 in the current era, and think about how we apply those lessons for future pandemics. And the first is that the pressure to deploy interventions, as happened in the early days of HIV and the early weeks of COVID, that pressure to deploy interventions must be tempered by the importance of finding out if a treatment or vaccine works. We all remember, perhaps all too vividly, the early weeks and months of COVID-19, how we and others were using therapies that turned out not to work. And an editorial we wrote in the throes of it was really an editorial that still speaks to me, where the title was called "Desperate Times Call for Temperate Measures." Really, the second point is that randomized trials not only can be done, but must be done during a pandemic. During a pandemic with a new virus, we don't know what doesn't work, and it's only through a randomized trial that we find out. That was the lesson of HIV, and certainly reinforced with COVID-19. And finally, and perhaps most importantly, equity must be at the center of our response. The lesson of the late and great Dr. Paul Farmer, he exemplified that, and I think we need to live up to that legacy. So with that, I'm going to conclude. Thank you all for your attention. Very much looking forward to the back and forth and the Q&A, and I appreciate the time we had together.